afternoon, and welcome to the October Virtual Diabetes Support Group meeting. Today, I am honored to introduce Dr. Lance Walsh, who came to Titus Regional Medical Center in March of 2019. Dr. Walsh is a specialist in urology, from treating kidney stones, benign prostate hypertrophy, incontinence, bladder prolapse, and hematuria. He specializes in minimally invasive and robotic-assisted laparoscopic surgery to help his patients. Dr. Walsh is also an amazing educator, as you will soon see, giving numerous presentations and also being published in more than 20 peer-reviewed research articles. He got his medical degree from Texas Tech University Health Sciences Center, where he was recognized with the Chancellor's Award. He did his residency in urology at UT Southwestern in Dallas. It is my distinct pleasure to welcome Dr. Walsh. I would just say that Dr. Walsh will be sharing about a complication of uncontrolled diabetes that is challenging to many men with diabetes and can potentially affect their health and well-being. And this presentation may not be appropriate for young children, so please listen with discretion. Welcome and thank you, Dr. Walsh.
Everybody. We did a similar presentation a year ago, and I think it was very well received. And so I'm going to talk about a couple of things that are very common in people that have diabetes. The first one is erectile dysfunction. And, it's something that is important that affects millions of men throughout the world and in the United States, and especially in our community. And I think it's something that is definitely undertreated. And you don't have to put up with it. There are treatment options, and that's one of the things I'm going to discuss. The other topic I'm going to discuss kind of goes hand in hand with erectile dysfunction. It's hypogonadism, which is low testosterone. So we're going to tackle both of these topics in the next 30 minutes. So I will start. So today regarding erectile dysfunction, you'll learn about several things, including the normal physiologic process of how an erection occurs, what erectile dysfunction is, what causes it. Important, ED is a health indicator. Did you know that if you have erectile dysfunction, it may be an early sign of coronary artery disease? And of course, as you know, coronary artery disease can lead to a heart attack. And then importantly, we'll discuss management and treatment options for erectile dysfunction. So how does a normal erection occur? Well, it's important to understand that having a normal erection is a vascular event. It's a vascular phenomenon. It occurs after sexual excitement that causes the blood vessels and hormones to work together to produce a rapid increase in the amount of blood flowing to the penis. The blood becomes trapped and held in the two spongy chambers in the shaft of the penis called corporal bodies. As the chambers rapidly fill with blood, they expand and the penis becomes firm and elongated. The result is an erection. Erectile dysfunction can be caused by physical disorders such as injury to the brain or spinal cord, diabetes or heart disease, an operation if you've had a radical prostatectomy, or sometimes a transurethral resection of the prostate can also do it. Also substance use, tobacco, alcohol, drugs, or other medications are common culprits. Like I talked about briefly, erectile dysfunction is a marker for cardiovascular disease. So if you have it, make sure you talk to your primary care physician or seek out a cardiologist to evaluate your heart. The penis is a vascular organ. Loss of erectile function is one of the earliest signs of endothelial dysfunction. And of course, endothelial dysfunction, the other ED, is an early marker for cardiovascular disease. So it kind of makes sense if you think about it, because the arteries of the penis are smaller. The earliest markers for coronary vascular disease are apparent in the penis. So an assessment of erectile status may indeed give clues to clinically silent yet progressive coronary, peripheral, or cerebrovascular disease, as well as to undiagnosed hypertension, diabetes, and other endocrine disorders. In fact, in this study that I listed below, a cardiovascular evaluation was conducted in 50 men with erectile dysfunction and asymptomatic for heart disease, meaning they didn't have any symptoms of heart disease. Of those men, 80% had multiple cardiovascular risk factors, almost half the men had abnormal exercise tests, and there was a high prevalence of coronary artery disease on angiogram. For instance, 12% of the men had left main obstruction or 3-vessel disease. 14% had moderate 2-vessel disease, and 14% had single vessel disease. So if you only learn one thing from this, if you have erectile dysfunction, get your heart checked. That can save a life. Let's talk about risk factors for erectile dysfunction. Medication's one of them. We talked about high blood pressure as a risk factor. Well, medications you take for high blood pressure can lead to erectile dysfunction or promote it. Psychosocial like depression, anxiety can impact it. Lifestyle. If you don't exercise, don't eat the right foods, you're more at risk for getting erectile dysfunction, and your overall health status. Of import for this diabetes conference is diabetes has one of the greatest risks for increasing the risk for erectile dysfunction. The age-adjusted odds ratio is more than 4 times compared with someone without diabetes. And then you can look at the host of the other problems that can also contribute to erectile dysfunction, like peripheral vascular disease, hyperlipidemia, and hypertension. So how do we treat this? Well, I'm going to review the various options, including lifestyle modification, oral and insertable drugs, injectable therapy, vacuum, and then finally the penile implant. And a word about cost is that, you'd think that, insurance companies would cover all of these treatments. In reality, the majority of them don't, except for the penile implant, which is a surgical procedure. So these other, the pills, the shots, the vacuum device, generally they're not covered by insurance companies, and generally they're an out-of-pocket expense. So let's talk about, lifestyle changes. Importantly, it's, if you're smoking, stop smoking, limit or avoid alcohol or drug use, follow a healthy diet, and exercise regularly. I mean, that's a good plan to follow, not only for erectile dysfunction, but for your overall health. When it comes to medications, I'm sure most of you have heard of Levitra, Viagra, Cialis. There are, in addition to the pills, there are injectable therapies. Most common one is Trimix. There are insertable drugs, vacuum pump, and then finally the surgical option, which is a penile implant. Of course, at the Advanced Urology Institute at Titus, we offer all of these therapies, and I'm very experienced in the surgical option as well. So let's look at the drug therapy first. Viagra, Cialis, and Levitra, they've been around a long time. One of the important things to understand is that they all have the same mechanism of action. So if you're on the max dose of one and switching to another is not likely to be more effective because they have the same mechanism of action. So what is the difference? Well, they have potentially different side effects as well as durations of action. Viagra typically lasts about 8 hours, where Cialis, can last for much longer than that. There's a daily Cialis that you can take as well. Cialis is the only one of these medications that's FDA approved for both BPH, which is benign prostatic hypertrophy, urinary problems, and erectile dysfunction. So if you suffer from urinary problems as well, Cialis is a good go-to. These pills may help achieve erections in response to sexual stimulation. So you have to be in the mood for them to work. They all share common side effects, including headaches, facial blushing, upset stomach, and mild and temporary visual effects. Another medication option is a transurethral medication that's inserted in the urethra. Generally, patients are more reluctant to use this, and I haven't used it much. It's the trade name is Muse. It's alprostadil. Vacuum pump. There are medical grade vacuum devices that are available that are generally very safe to use. It's for people that either the medication has failed or they don't want to use medication. Generally, it's the most cost-effective treatment for erectile dysfunction because once you buy it, it lasts a long time. In terms of the quality of the erection, it's generally cooler than what a normal erection would be. Of course, you have to place a ring at the at the base of the organ in order to maintain the erection. Another treatment option is a drug therapy. Generally, you choose drugs, or you choose an injectable therapy when the oral medication isn't effective. It's fairly reliable, more instant, and gives a predictable erection. In fact, it works by directly causing the vasodilation of the blood vessels, so it doesn't require stimulation for it to work. Generally, it can be more cost effective than the oral medications, but it depends on how much volume is required to achieve the desired result. Generally, we start at a low dose and then titrate to effect. Finally, I want to talk about the two surgical options. One is the malleable implant, which is seen on the right. The other one is the inflatable implant, which is seen below. These are made through small incisions between in the private area. The malleable implant, the advantages include easy for you or your partner to activate. There's good option for men with limited dexterity. Both of these surgical options are totally concealed in the body. The malleable generally is the simplest surgical procedure, and the prosthesis is least expensive. The disadvantages is that because it's malleable, it bends up and down. It may show through your clothes, and it stays firm when not in the erect position. The kind of the Cadillac or gold standard for treatment of erectile dysfunction, the surgical treatment, is an inflatable penile prosthesis. The advantages: it's easy to use. It's a one-step deflation, totally concealed in the body, offers natural flaccidity compared to non-inflatable implants. It acts and feels more like a natural erection, expands the girth of the penis, and is more firm and full than other implants. In terms of satisfaction rate, these devices have been around more than 40 years with multiple iterations and improvement as generations improve. Literature supports a great patient satisfaction rate, well over 98%, and partner satisfaction as well. Reliability shows mechanical reliability rates of over 97% at 5 years. These are concealable, and again, they're covered by insurance, which is important. Any surgical treatment does have risks. The main risks for an implant include infection, erosion, migration, chronic pain, and device malfunction. Most insurance will cover the surgical implant, and that includes Medicare. And we have reimbursement specialists in our office that can help confirm your coverage. So what's the next step? It's important, if you suffer from this very common medical condition, you're not alone. Let your primary care physician know, or call my office. We'll be happy to see you. Here's a treatment algorithm for erectile dysfunction. If you have this condition, you want to see your primary care physician or your local urologist. We will definitely recommend you get an evaluation for your cardiovascular risk factors. And if present, we'll have workup for vascular disease or coronary artery disease. To schedule an appointment and to speak with me or my nurse practitioner, please call our number, which is listed here, 903-434-7111. Again, we'll be happy to confirm your insurance coverage. So let's switch gears a minute. So we talked about erectile dysfunction, which is a vascular event. But there's an associate here, testosterone. How does testosterone affect erectile dysfunction? And the idea is that if you have erectile dysfunction, just giving testosterone isn't enough. It doesn't affect the vasculature. It doesn't lead to getting an erection. What it does help with is your libido or sex drive. So oftentimes in men that have low testosterone, they may have symptoms including low libido or sex drive, fatigue, decreased muscle mass, decreased depressed mood. So a low testosterone, it's important to understand, isn't just a low laboratory value. Hypogonadism is a low laboratory value plus an array of these symptoms, some of which I just presented. It shares a lot of the same comorbidities as erectile dysfunction, and especially diabetes. So if you're diabetic, it's probably a good idea you can get your testosterone checked. So let's talk about the evolution of testosterone replacement. The first synthetic testosterone was made by German and Dutch scientists in 1935. There was chemical modifications in injectable forms that became the preferred delivery method in the 1940s. Oral forms were introduced also in the 1940s, but they were toxic due to liver problems. Implantable pellets were synthesized and approved, but never marketed in 1972. And subsequently, topical patches were developed and launched in 1994. The gels were introduced in the United States in 2000 and 2003. And then Testapel, the implantable pellet, was available in 2008. Testapel is very effective at increasing your testosterone levels. It is an implant, and it lasts for up to 6 months. It results in improved compliance and reduced costs. If you look at the amount of pellets, Testapel on the right versus gels for a 4.5 month supply, I think the picture tells 1,000 words, right? The various options include topical gels, intramuscular injections, patch, lozenge, and the Testapel implant. The Testapel implant has been studied in a single retrospective analysis of medical records from 2007 to 2009. Almost 65 patients had the subcutaneous pellet inserted, and there were no surgical site infections during that time. The implantation occurs in the hip area, and it's a small procedure that takes approximately 5 minutes, where a small incision is made in the hip area in the fatty part above the buttocks, and anesthetic is used, and then the implants are placed, and they are a slow release over a period of, like I said, 4 to 6 months. Testapel or testosterone is indicated for the treatment of conditions associated with a deficiency or an absence of endogenous testosterone. So if you have breast cancer or prostate cancer, you shouldn't take Testapel or testosterone. And obviously, pregnant women should not take this medication. So a quick word about how the patches, gels, and injections work, okay? On the x-axis is the time in days, and in the y-axis is the testosterone level. So the red graph indicates the injection. So after the testosterone is injected, it quickly reaches high levels, and then that levels decay over time. Generally, we do testosterone cypionate that's injected 1 milliliter every 2 weeks. We could do it in our office, or if you feel comfortable, you could do it at home. Another treatment is the patch or gel. This requires daily dosing by applying the gel or patch to your body. And it requires daily dosing in order to keep the testosterone within the normal range. If you compare that to if we use pellets work over the frame of months. You're talking about 4 to 5 months duration, making it very good for compliance. So if you travel a lot and you don't want to carry the gels with you, a testosterone implant can be very effective. So testosterone pellets are well tolerated and easily implanted. Generally, insurers will set the number of pellets that they will cover for a duration of time. If you have Medicare, generally Medicare will approve 6 pellets for 3 months. A lot of private insurers can approve up to 12 pellets for 4 months. Again, if you have any questions, please call us at 903-434-7111. Look us up on Facebook and go to our website. We have a we have a wealth of information for you. I want to thank Christina for giving me this opportunity to present on 2 very important topics for men with diabetes. And again, we are very happy to help you in this. And If you need to see your primary care physician, please do so, or you can contact our office directly. Thank you very much.
Thank you, Dr. Walsh, for this very informative presentation. It's never pleasant to discuss complications when it comes to diabetes, but I think it's vital that we discuss them and certainly their prevention and treatment options that are available for them. Today, I'm going to share a little information also about tightening diabetes control, because uncontrolled diabetes can lead to some of the issues that Dr. Walsh was sharing today. So there's 3 letters, ABC, easy letters to remember, and they certainly are very pertinent when it comes to helping yourself be protected from diabetes-related complications. Diabetes is a disease that can affect just about every area of your health. And elevated blood sugars increase your risk for several long-term complications. I show several here, like kidney disease, eye disease, heart disease, foot and healing complications, foot wounds, and which can ultimately lead to amputation, nerve or neurological issues, and even blood pressure issues. So A stands for the A1C, sometimes known as the hemoglobin A1C. It's a blood test that tells us the average of your blood sugar or blood glucose for the last 2 to 3 months. Your A1C should be checked by your healthcare provider at least every 3 to 6 months. And the American Diabetes Association recommends that the A1C goal should be less than 7%, which is a 3-month average sugar of approximately 154. Now, that does not mean everyone's A1C goal may be 7%. This can be individualized depending on your health concerns by your physician, but the general target is less than 7%. Lowering your A1C just 1 percentage point, if it's been elevated, has a sizable reduced risk for several serious complications. You can see here, for example, 21% decreased risk for diabetes-related death, 14% decreased risk in heart attack, 12% decreased risk in stroke, 43% decreased risk for amputation. So lowering your A1C, if it has been above the target listed on this screen, it is vitally important, and it can absolutely reduce your risk for other diabetes-related complications and problems. Blood pressure, B stands for blood pressure, and very simply put, this test checks the force of the blood flow through your blood vessels. High blood pressure increases the risk of a person's risk of heart disease, stroke, kidney damage, and even damages the blood vessels in the eyes, and it makes blood vessels less elastic. High blood pressure is devastating in what it can do. It can affect so many parts of our body, and blood pressure should be tested at every doctor's visit. And your doctor, your healthcare provider, may also recommend testing at home as well. A general target, again, this might be individualized to you, but a general target is that the blood pressure should be less than 140/80. C stands for cholesterol, and high cholesterol can lead to fatty buildup called plaques in our arteries, increasing our risk for heart disease. Your cholesterol or your lipid panel should be tested at minimum at least once yearly. Again, it may be tested more often. That target might be individualized, but the general target for cholesterol is that the total cholesterol should be less than 200 milligrams per deciliter, the LDL cholesterol less than 100 milligrams per deciliter, the HDL cholesterol, also known as the good cholesterol, greater than 40 for men, greater than 50 for women, and triglycerides less than 150. So a form of diabetes-related complication affecting urological health is autonomic neuropathy. This form of neuropathy or nerve damage affects the nerves that control our heart rate and blood pressure, and they even affect the nerves that affect blood sugar control. It also affects internal organs, causing problems with digestion, respiratory function, urination, sexual response, and vision. Nerve damage can prevent the bladder from emptying fully, allowing bacteria to grow in the bladder and kidneys and causing more urinary tract infections. Another consequence of this nerve damage can be urinary incontinence, as a person can no longer sense when their bladder is full or control the muscle to release urine. So here are just some basic suggestions or solutions. Absolutely, if you feel like you might have problems, please see Dr. Walsh and his excellent team at Advanced Urology. Certainly, if your diabetes has been out of control, focus on steps. Talk to your provider about steps to help you better manage your diabetes. Make sure that you know where each of your ABC labs is relative to that goal. If you develop a urinary tract infection, follow all instructions given to you by your healthcare provider, including taking the full course of antibiotics prescribed. Drink plenty of sugar-free, yes, I did say sugar-free liquids, and preferably more water. If you've been diagnosed with incontinence, try to urinate at a regular interval, like every 3 hours, so that you don't end up in trouble. So, in conclusion, neuropathy affects more than just our feet, our toes, and our hands. Neuropathy can affect problems in the digestive tract, in the heart, sexual organs, and even our urinary tract too. Treatment of diabetic neuropathies first involves bringing blood sugar levels or blood glucose levels within normal range. Good blood glucose control may help prevent or delay the onset of further problems. If I can be of any assistance in helping you identify ways that you can better manage your diabetes, I hope you would reach out to me. My phone number is 903-577-6099, and I would be happy to answer any questions or concerns you have. And I would also just reiterate, if you're having concerns that are urological in nature, we are so blessed to have an excellent team at Advanced Urology, and their number is 903-434-7111. If they can be of assistance to you, I would encourage you to take advantage of their expertise. Thank you, and I wish y'all a wonderful rest of the day.